Hello, welcome to your liver transplant orientation. Please write down any questions you may have, and we will be happy to answer them at the end of the presentation. Today, we will go over liver transplantation in two parts: living donor liver transplantation and deceased donor liver transplantation. The living donor portion of this presentation will be presented by one of our transplant hepatologists, Dr. Peterson.
Hello, my name is Dr. Mark Peterson. I work as the Medical Director of Living Donor Liver Transplantation alongside Dr. Madhukar Patel, the Surgical Director. I am happy to share with you a new opportunity to significantly shorten your waiting time on the transplant list: living donor liver transplant. When it comes to liver transplant, there are two main types of donors: living donors and deceased donors. Deceased donors come from those with a brain injury that they won't recover from, or whose family chooses to take them off life support. Living donors are people who have volunteered to donate a part of their liver. The liver sits in the right upper area of your abdomen. When a person donates, they typically donate the right lobe of the liver, about 60 to 70% of the total liver volume. The donor retains the left lobe, or about 30 to 40% of the liver volume. One unique aspect of the liver is that a healthy liver can regenerate. So over the course of about 2 months, the liver regenerates to 97 to 98% of its original size in both the donor and the recipient. Who is a candidate for living donor liver transplant? Are patients who only need a liver transplant. So this does not apply to those who need 2 or more organs, for example, both a liver and a kidney. Why is it important to consider living donor liver transplant? Well, I'll start with the MELD score here. As you all know, the MELD score is a number that is calculated based on your labs, and it ranges from 6 to 40. Patients with a MELD score of 40 are the sickest, and they are the highest priority on the traditional liver transplant list. The MELD score is used for the transplant list because it fairly accurately reflects the chances that you might die within 3 months. So if your MELD score is 18, then your chances of dying in 3 months would be 5 to 9%. This is also why we work so hard to find all of our patients a suitable donor organ as quickly as we can. The advantage of living donor liver transplant is that you no longer have to wait for a transplant. A living donor can decrease your risk of dying on the transplant list by 30 to 40%. Other advantages of living donor include you are less sick when you need a liver transplant. This means a quicker recovery because this is an elective, non-emergent surgery. The ideal donor has an age of 18 to 60, a BMI less than 35, and has their own health insurance. The health insurance for the donor is not to cover the cost of donation, but to cover any incidental findings that might come up throughout the course of their evaluation. Costs for the transplant are covered by the transplant center by way of the recipient insurance. Donor assistance funds may be available to help cover some of the costs of travel and housing based on income through the National Living Donor Assistance Center. Please know, though, that it is unlawful to provide financial or other incentives for organ donation. How is this paid for? Again, by the recipient's insurance. Liver donors are not responsible for the cost of the donation workup, hospitalization, or complications related to the liver donation. Finding a living donor can be difficult and sometimes may feel uncomfortable. However, given the extensive workup performed, usually 3 to 4 donors are needed to step forward in order for one to ultimately be suitable. So here are some tips to get started having the conversation. First, you will need to disclose your need for a liver transplant, although you don't necessarily need to disclose why you need it if you're not comfortable doing so. Next, discuss the advantages of a living donor transplant, and that this is the recommended treatment option for your liver disease. Seek people who might be interested in donating, or that might be a champion to help you find someone else who might be interested in donating for you. Finally, emphasize that a potential donor is under no obligation to donate and that his or her decision will not affect your relationship with them. Of course, do not pressure a potential donor to say yes. If they have any questions, ask them to contact us for more information. If you would like additional coaching or instruction on how to find a champion or a donor, please reach out to your coordinator to set up a meeting with our living donor transplant champion, Taylor McClaskey. Donor safety is our primary concern. Donors get their very own evaluation to ensure the donation is as safe as possible. Decisions are made by the Transplant Evaluation Committee, which consists of the entire transplant team. All discussions are confidential. To be approved as a donor, the committee must believe donors will not be negatively impacted by donation, including physically, socially, emotionally, or financially. We are committed to maintaining the confidentiality of both you, the recipient, and your potential living donor. The donor and recipient will have two separate teams of providers. No information will be shared between our donor and recipient teams. A donor cannot be pressured to donate. Organ donation must be a voluntary act on the part of the donor. Assuming a donor is approved, a transplant can then be scheduled on a day that is convenient for you and your donor. When you receive the graft, it will also regenerate to 97 to 98% of the full liver within 2 months. So what does the course look like for the donor? Well, after donation, donors are generally in the hospital for 3 to 6 days. The average recovery time is 6 to 12 weeks. Donors should be prepared to take the full 12 weeks off for recovery. About half of donors are able to return to work at 4 weeks. 3/4 of donors can return at 8 weeks, and almost all donors return to work by 12 weeks. Some of this does vary based on what kind of job you have. For those with a desk job or those who work remotely, they may be able to return to work earlier. Those who have more active jobs, such as working in a warehouse or working construction, might take the full 12 weeks to return to work. This concludes the portion on living donor liver transplant for this presentation. If you have any questions going forward, you are always welcome to reach out to your coordinator or to ask to speak with our living donor team, and we are happy to provide you with further information about living donor liver transplant.
Here you have your liver transplant team, also known as the committee. Our team is made up of transplant hepatologists, surgeons, nurse coordinators, pharmacists, and several other multidisciplinary groups. Now that we have discussed living donor transplantation, let's get into deceased donor transplantation, next steps, and expectations. The journey for the transplant candidate and family includes the evaluation, waiting for a matching liver, the transplant surgery, and recovery. Our goal is to help recipients feel better and enjoy a better quality of life. Patients are referred to our clinic for consideration and evaluation for transplant if they have a clinical indication or medical need for liver transplantation, for which no other therapy is available. A few of those examples are below. Patients with acute or chronic liver failure may often suffer from ascites or fluid in the abdomen. This can be medically managed with diuretics, also known as water pills, to maintain an adequate fluid balance. Another side effect of liver disease is encephalopathy, that mental fog or confusion patients often experience. We also can prescribe medications for this to remove the buildup of toxins from the bloodstream. One common medication used is lactulose, which binds to ammonia and is removed through the stool. If indicated, we screen regularly for varices and GI bleeding with upper endoscopies and colonoscopies. Electrolyte imbalances are typically caused by regular diuretic use. We will monitor with labs and adjust and replete as needed. The evaluation process will determine whether transplant is the best option for you. However, these are some of the reasons transplant may not be a good option. For example, if you have cancer, we will need this to be treated and a cancer-free period may be required to move forward. Another example is heart disease. We will perform testing to ensure your heart can withstand the stress of surgery. If you need treatment, we will require this to move forward. For some patients, advanced cardiac and lung disease is permanent and we cannot safely transplant you. If you are a smoker, we will require you to quit smoking as this can increase the risk of complications during your surgery and post-transplant, especially in terms of cardiac disease, lung disease, and peripheral vascular disease. Also, if during the pre-transplant phase we find you are at risk for non-adherence and medical non-compliance, transplant may not be an option for you. This is an overview of the process for deceased donor transplant. You have already been through the intake and insurance clearance process. So today, you are in between steps 2 and 3. By completing this orientation today, you are beginning your liver transplant evaluation. During your transplant evaluation, your appointments will involve a transplant surgeon consultation, health maintenance updates, imaging, and cardiac testing. In addition to the medical evaluation, you will also be seen by a social worker to ensure that you are ready and understand the risks and benefits of transplant, in addition to having support to assist you on your transplant journey. It is highly suggested that the person you have designated as your support be with you for this appointment. Overall, we want to ensure you have no barriers to transplant. Our goal is to get you through the evaluation process as quickly as possible so that you can start accruing time on the wait list, getting you closer to transplant. Please notify the transplant office if you need to cancel or change appointments. Your transplant coordinator will guide you through this process and be your contact person for this leg of the transplant journey until you are transplanted. All potential candidates for liver transplant will have their cases presented to our liver selection committee to determine whether transplant is the best option for you. This is a multidisciplinary committee composed of hepatologists, surgeons, social workers, coordinators, dietitians, pharmacists, psychologists, and financial coordinators. No one person makes the decision regarding your candidacy for liver transplant. It is made by the team. After careful review of your case, the team will make a decision. There are 3 possible outcomes. If you are approved, this means there were no barriers to transplant and no further testing is needed. If you are deferred, this means that something in your evaluation for liver transplant may need to be looked at further. For example, if you had a stress test that was not quite normal, the team may require a more advanced study to ensure it is safe for you to move forward with transplantation. If this is the case, we will notify you of the committee outcome and explain the reason for the additional testing. Once that testing is completed, we will represent your case to the committee for determination. If that new testing proves there is no barrier to transplant, you will then be approved. Should there be a barrier we cannot fix and we determine transplant is not a safe option for you, your case will be denied. As mentioned before, this could be heart or lung disease that is not curable, cancer, or other issues that could complicate your success during and post transplant. We will always notify you of the committee decision and be available to answer any questions you may have. So your evaluation has completed and you have been approved. You are now placed on the transplant wait list. Patients are waitlisted according to blood type, MELD score, and BMI. Once waitlisted, you can be placed into one of three status levels. The first is the active status. If you are listed active, this means that you are ready for transplant offers and there are currently no barriers. Status 1A is acute and sudden liver failure. Patients who are listed status 1A usually do not live more than a couple days without a liver transplant. Lastly, status 7 or inactive status means that something has happened and you are no longer ready for transplant. When you are inactive, this simply means that you will stop accruing time on the transplant wait list. There are several different reasons why we would place a patient inactive. First, you have been too sick for a safe surgery. Next, there could be a non-adherence or inability to contact you. If we, as your liver transplant team, cannot contact you, we have to assume that those donor coordinators offering livers cannot either. So please be sure if you have a change in contact information that you let us know. Every 6 months to a year while you're waitlisted, your testing will need to be updated. If this testing falls behind, you run the risk of needing to be inactivated on the waitlist until the testing is updated. And lastly, if there are any insurance issues, such as a change in insurance, a loss of insurance due to losing employment, we will have to inactivate until the new insurance authorization for transplant is established. Liver transplant is allocated by urgency. This urgency is determined by a system called the Model for End-Stage Liver Disease, or MELD. The MELD score is calculated based on lab values from your total bilirubin, creatinine, INR, and sodium. These results are placed into a formula that gives you a result of 6 to 40. The higher the score, the more urgent need for a liver. This chart shows your MELD recertification schedule. Once you are listed, your MELD score will need to be updated regularly, depending on what the new lab values are. When your coordinator calls you to have updated MELD labs, please be sure to make a plan to do this as soon as possible, as expired MELD scores will drop down to the lowest value of 6 if not updated on time. Liver organ allocation focuses on medical urgency of the transplant candidates and the distance between the donor hospital and the transplant hospital. Livers will be offered first to the most urgent transplant candidates. That is, again, those patients in the category status 1A, followed by top MELD scores, and those listed at transplant hospitals within a radius of 500 nautical miles from the donor hospital. So the following offers are made according to MELD score and the hospital within distances of 150, 250, and 500 nautical miles of the donor hospital. Waitlist and donor risk. This is a very important slide. Be sure to pay attention and write down any questions you may have for us to answer at the end of the presentation. We will be asking individually for a yes or no for these different types of donor risks. So again, be sure that you think about this and write these down, and we will call you at the end of the presentation. No transplant is without risk. Potential donors go through a rigorous screening process in an attempt to ensure that their organs are appropriate for transplant. But there is a risk of disease transmission with deceased donors that may not be evident at the time of organ offer, including but not limited to hepatitis C, hepatitis B, HIV, and other infectious diseases. Our goal is to find the best possible liver for you, given your MELD score and clinical condition. If you have received a liver offer, it is because our surgeons feel that liver is better than the liver you are currently living with. Waitlisted patients are ideally given a standard criteria donor liver, but have the option of accepting other types of livers, including a liver from a donor who has been exposed to hepatitis B, core antibody positive liver. These organs come from donors who have been exposed to the hepatitis B virus in the past. There is a very small risk that donor liver would transmit hepatitis B. Hepatitis B infection can often be prevented by treatment with the medication started after the transplant. You will need to take this medication for the rest of your life. This medication prevents infection in more than 90% of recipients. Next is a liver from a donor with PHS increased risk. PHS is our Public Health Service guideline. Blood work is done during the donor evaluation to screen for potential infectious disease to ensure they are currently negative. If donor exposure was recent, there is a risk that the disease will not be detectable at the time of the evaluation, and that you may be exposed to a potential infectious disease. The results with transplant from these donors has been equal to standard donors. More specifically, the PHS increased risk could be organs that come from donors who have been incarcerated, lived in group homes, men who have sex with men, women who have been involved in prostitution, IV drug use, tattoos. Again, these donors will be screened very rigorously to be sure that they are negative of any infectious diseases. Should they be negative, you could receive one of these as an offer. Next is a liver from a donor who has a history of cancer. Sometimes we are offered organs from donors who have a history of cancer. We do not use organs from donors with a very high risk of transmitting cancers. However, there may be some donors where the risk is known to be low. If we determine that the risk of cancer is lower than the risk of you dying before you get a transplant, we may offer you one of these organs. Next is a liver that has been split to share with another recipient. A single liver from one donor may be divided into two pieces to transplant two patients. This is called split liver transplantation. We usually can do this by giving the smaller piece to a child and the larger piece to an adult. Sometimes the liver may be divided between two adults. There are higher risks involved in receiving a portion of a liver instead of the whole liver, including bleeding or bile duct problems, but these are overall high-quality livers. Next is a liver from a donor who is older than 70 years old. The average age of donors has increased significantly in the last 10 years. Although livers from donors greater than 70 years old may function very well, they may have a higher risk of complications immediately post-transplant. Next is a liver from a donor who has died of a cardiac event rather than brain death. Most organs today come from donors who die of brain death, meaning the heart is beating up until the time of organ removal. There has been an increase in use of organs from donors where the organs are removed for transplant after the donor's heart has completely stopped. This is a donation after cardiac death. There are increased risks that livers from DCD donors compared with brain death donors, the liver may be slower to work early after transplantation and rarely may need to be replaced. There is also a higher risk of bile duct problems. We have strict criteria for use of cardiac death livers in order to minimize these risks. Next is a liver from a donor with hepatitis C, antibody positive, NAT negative. These livers could come from donors with a prior infection with hepatitis C or possibly a false positive test. You would need to be monitored after transplant to make sure you did not develop hepatitis C, and on the small chance that you do, you would then need to undergo treatment for hepatitis C. And lastly, a liver from a donor with hepatitis C antibody positive, NAT positive. These organs come from donors who have been infected with hepatitis C virus. If you have had hepatitis C in the past and been treated or currently have hepatitis C, we will not offer one of these organs to you, mainly because most insurances will not pay for treatment of hepatitis C twice. At the end of this presentation, each patient will be called individually and asked if they would like to accept an offer from each of these high-risk donor types. Keep in mind, saying yes to an offer of one of these high-risk livers does not guarantee you will absolutely be transplanted with one of these livers. This simply opens you up for more offers and once a liver becomes available to you, you do have the option of saying no. If you turn down a liver offer, this does not affect your status or placement on the wait list. You will just continue to wait for the next available liver offer. Things to remember while waitlisted. You must keep us updated of your personal contact information as well as the phone numbers of any of your emergency contacts. If we cannot find you, we cannot offer you a transplant. It is understood that we live in a day and age where spam calls happen often, but be mindful that once you are waitlisted, our donor coordinators live all over the United States, so you may get a call from an out-of-state number offering you a liver. If your status on the waitlist changes, be that active or inactive, even a MELD update, we will give you a call and you will receive a letter of status change. Be sure to keep us updated if you get sick, have any health status changes, or if your insurance has been lost or is changing. Failure to let us know these things could affect your transplant candidacy if we do not know ahead of time. Continued things to remember while waitlisted. We do return urgent clinical calls the same day. Examples of urgent clinical calls are prescription refills, abnormal lab values, or urgent symptoms. Our goal is to return all calls the same day, but any non-clinical, non-urgent calls may be returned within 24 hours. Examples of non-clinical calls would be calls related to any paperwork, like Social Security forms or FMLA, normal lab results, or general questions. Calls received on holidays, late afternoon, or late Friday may be returned the next business day. For my chart messages, please be sure not to use those in the case of an emergency. If you have an emergency after hours or weekend, our phones are answered 24 hours a day, 7 days a week to assist with all of your urgent needs. Multiple listings. Some patients may want to list at multiple centers, potentially increasing their chances of getting a liver sooner. We support you if you would like to pursue this option and will supply your chosen center or centers with the records they need to determine your candidacy by their center's standards. Our goal is you receive a transplant. We would love for it to happen with us, but we will be just as happy if you receive an offer through another center. Things to remember: when you get a liver offer from a particular center, you are transplanted at that center. For example, if you are listed at UT Southwestern and another center, and UT calls you for a transplant, you will have surgery at UT Southwestern. The second thing to remember is that it may not be beneficial to be listed at centers within the same organ procurement area, as this will not increase your chances of being called sooner. So if you are listed at UT, you may want to pursue listing in San Antonio, as this will be another organ procurement area. Talk to your transplant coordinator about dual listing, as they can guide you through the decision-making process.
Now let's move over to the hospital course. What you can expect when the transplant happens. Let's talk about the moment that you'll receive an offer. You'll receive a phone call from the donor coordinator notifying you that a liver is available. Remember, answer your phone, as the call could come from any area code. The donor coordinator will direct you to the hospital for admission at Clements University Hospital. Once you're admitted, there's a rush of activity as you're prepared for surgery with lab work, an EKG, and a chest x-ray. You'll see the physicians who will ensure you are ready for transplant and consent you for the surgery. They will also discuss with you the type of donor that you've accepted and give you an opportunity to ask questions. We want you to feel confident going into your surgery. The transplant surgery takes about 4 to 6 hours. Many times, blood products are used during the surgery. If you have any concerns about this, please discuss it with your hepatologist, your surgeon, or your pre-liver transplant coordinator. After surgery, you'll be transferred to the intensive care unit for a short stay, usually about 24 hours. Then, you'll be transferred back to the transplant floor for approximately 4 to 7 days. The nurses on both of these units have been specially trained to take care of post-liver transplant patients. While you're on the floor, you'll be taught about your medications, how to take care of yourself at home. They'll get you up to walk around. Usually the first time will be with physical therapy. Your labs, your medications, and your vital signs will all be monitored carefully. The transplant team will decide when it's appropriate for you to discharge. Typically, that's 5 to 7 days after your surgery. You'll be learning many new things about how to take care of yourself at home, so we encourage your social support partner to participate in your care at the hospital as much as possible. You'll be given a binder by your post-transplant coordinator that contains information that will help you through your post-transplant journey. There are some modifications to your home environment after transplant. Pet birds should be removed from your home. You can have a cat or dog, but you should not empty or clean the cat's litter box. After transplant, frequent lab work is required, usually twice a week initially. This lab work is timed and has very specific instructions. Please follow those very carefully as we will be monitoring your anti-rejection medication in your bloodstream. Weekly face-to-face clinic visits to see the surgeons are needed for the first month after transplant. If you live outside the Dallas-Fort Worth area, it will be necessary for you to plan to stay in this area for approximately 1 month after your transplant. We also advise that you should never take any other medication, prescription or over-the-counter, without checking with your transplant team first. It's critical that you attend all of your follow-up exams, complete every lab test, and take your medications as recommended by your transplant team. After transplant, you will be taking 2 very important classes of medications. Immunosuppressants are to prevent rejection of your new organ. This will reduce your ability to fight off infections. Therefore, you will also be taking medications to prevent infections, antivirals, antibiotics, and possibly antifungals. There are many drug interactions with transplant medications, so we ask you to avoid additional over-the-counter medications and any herbal supplements. There are several risks that are noted with transplant. Some of those are recurrent disease, osteoporosis, malignancy, or even the need to be retransplanted. You, along with your hepatologist and surgeon, will need to weigh the risk versus the benefit of transplant. The Scientific Registry of Transplant Recipients, or the SRTR, is an organization that collects survival data information about every solid organ transplant program in the United States. This information is reported twice a year. While waitlisted, you will receive this information directly. The graphs will compare UT Southwestern's survival data against the national average. If you have any questions about how to interpret any of the information on the SRTR website, please contact a member of the transplant team. As a reminder, our transplant team is available 24 hours a day, 7 days a week to assist you with all your transplant needs. The clinic number is 214-645-1919. We appreciate your time and attention to this session of the Transplant Education Orientation session. As we've mentioned before, please write down your questions and comments, and we will call you at a later time to discuss those. Thank you very much, and we wish you the very best.